right, let's start off with one that's a little open-ended. Dr. Zakowski, how will MACRA affect me?
Well, that's a very long, complicated answer that probably goes beyond the scope of the conference, right? When they eliminated the SGR fix, Sustainable Growth Rate fix, which was threatening to keep reducing Medicare payments to physicians, part of that involved going to other metrics, which wind up putting you to benefit or at risk for stuff. You could opt out and do an alternative payment model where that would exempt you. Most of that deals with, again, comes from government, so that's Medicare. Doesn't particularly affect OB anesthesia per se. I can tell you via my different hats, we're trying to find a good measure we can all agree upon for OB anesthesia to include in the quality metrics, like the ASA sponsored database. You can choose to some degree what metrics you want to report in order to meet some of these guidelines, and there's been a lot of back and forth about what would be an appropriate OB anesthesia metric and what would be the secondary consequences. For instance, even something as what might appear straightforward like post-dural puncture headache rate. Some people are afraid that if it becomes a measured metric, well, people won't say they had a wet tap, and then that's going to put the patient at risk because the next person coming along won't know, and sort of secondary effects like that. But the short answer is not a problem right now.
Next question. Two questions on the Dr. Macario, the surgical surgical HCA, I don't know how to pronounce that one.
S-caps.
C-cap. Say it again?
Surgical
Yeah,
caps? No?
S-caps. I don't know,
H-cap,
I wrote it down a
S-cap.
little differently here. It's anesthesiologist focused. What do you do when you have a mixed care model? How do people field that? Any sense?
Yeah, that's just one of the many challenges. The variety of practice patterns around the country, who the providers are, is not really specifically addressed in the SCAP, so we need to do something about that.
Here's an open-ended one, Mark. What's the best way to advocate at the local level? I presume that means the hospital?
Yes. Well, 80% of success is participating, so you got to be there. You show up to the committee meetings. I know it's hard sometimes. If you're in the OR, do you have to miss a case, get there, whatever. But, your group should make an effort to help put you and let you participate on the committee so you can be there to answer questions. Sometimes stuff comes up which is not favorable to our specialty, so if you're there to answer and respond, that's extremely helpful, as well as to promote policies and participate in terms of, for example, after lunch, I'll be talking about obstetric hemorrhage protocols, so that would be a good one, right? So, but just being there and advocating, speak up if you see something wrong.
Dr. Macario, what does one do when you identify a failure, in this case, an untimely epidural request? How is it best to field it in terms of these satisfaction surveys? Should one fall back on personal failure or more of a system failure? What are your thoughts on that?
You're talking about a person on labor and delivery who is requesting an epidural?
Yep.
And is not, there's no one.
Took a while to get there.
Oh, right. Yeah, well.
Do you throw the hospital under the bus, or do you own it?
Yeah. I think that's a difficult question, because I think not only is politics local, but every problem like that is local and really only has a local analysis that is deserved and required, and then a local solution. It'd be nice to say what to do about that kind of problem, but every practice is so different, it'd be hard to come up with an answer. So if there's no contract between the hospital and the labor and delivery suite to provide 24/7 labor pain relief, and the practice at the local hospital is to have someone who's in between cases and do a labor epidural, maybe that's a totally different situation than a big university center where you have several OB anesthesiologists and fellows and residents to do labor pain relief. So I think you have to look at it at the particular characteristics of that situation. Sorry.
Well, I think if you're talking about at the patient level, you know, don't BS. Just, you know, give. Most people can tell when you're telling the truth or not, or when they're being BS or given a blank answer. And there's enough chit chat that goes on. Sometimes they hear, like, oh, there was a crash. You know, they hear the nurse talking about it. So if you were delayed by an emergency, you say, oh, I'm sorry, we had an emergency we had to deal with first. You know, I guess I've survived long enough and had the privilege to train 600 or 800 residents and nurse anesthetists, so I have a good pool connection for what goes on out there. I know medium to smaller places where the nurses, the L&D nurses, heavily cooperate with the anesthesiologist or nurse anesthetist in terms of timing. Oh, and you know, like same thing, I have a problem where they wait till the last minute, more so now, and then they want you to show up instantly, despite the fact that there are probability times when I could tell you when the requests come more often. And in these other places, the nurses, or I don't know if it's a charge nurse, works closely with the anesthesiologist to say, oh, there's a section coming up, can you do this epidural before you go back, or, you know, kind of work with it so that they understand that it's a time-limited resource and work with you better to manage the workflow.
I would add to it that I would generally be dissatisfied if I am registering a complaint to have buck passing between different elements within the healthcare organization. I would assume unity. That's what I would expect. If you have systems problems, I want you to figure these out before I get there. But I certainly observe that to a great degree. In my general sense, I'm not sure what yours is as an audience, but I would find that a little dissatisfying, passing the buck. Dr. Macario, here I've been trying to balance the questions, one for each of you, but the reality is it probably should be a 2-to-1 ratio, given the lecturing here. A scheduling question, Dr. Macario, is it best to schedule the longest cases first?
Oh yeah, that's a great question. I think if you look at the, again, it depends on the place and the local characteristics, and so it's difficult to give an answer that applies to everything. I mean, sometimes people say, well, we know we have a long turnover time, what should we do about that? Well, you gotta look at the processes at your facility and figure out what the root causes are and work your way up to figure out what the solution, and the same thing here. So imagine if you're a surgeon in a community practice and that surgeon operates at 3 or 4 hospitals and they want to do their short case first because of whatever reason, and if they don't have that request approved, they're going to take their cases elsewhere. So in that situation, I would say it's best just to do the cases in the order the surgeon wants them, because the hospital and you as an anesthesia group don't want to lose that surgical activity to another hospital. In contrast, if you work at a center where the surgeons and all the doctors and nurses are all work for the same institution, maybe an HMO or university, and you're really focused on throughput and getting the most work done, you can make the argument it makes sense to do the long case first. And then it depends on what the approach of the operating room leadership is about starting cases after the block time is, and what their availability to staff after 5 o'clock. So, for instance, if you had a situation where the surgeons and the hospitals and the anesthesia group had agreed to provide anesthesia care after 5 because of the local characteristics of the market in that city, then you could argue it doesn't matter which case goes first because we're going to do them both and we're equipped and staffed and expecting to do both, even if they do go late. On the other hand, if all your staffing leaves at 3 o'clock, then you can make the argument, yeah, we should definitely do the longest cases first because we want to get that done and we don't want to for sure be going over. So it depends.
Depends again. Alex. This group's trying to pin you down.
Yeah.
All right, a question for either of you, although it seemingly falls within your last lecture. In the setting of, in regards to these satisfaction measurements and the pain question specifically, in obstetric anesthesia, often a patient would choose natural childbirth. How does that figure into some of this pain score collection in contrast to some surgical services? Either of you field that one.
So there's as we say, the common measurement, right, the VAS pain score, which the nurse does ask and record, compared to the patient satisfaction with it. So if you have someone who wants more of a unmedicated birth, they're less likely to take some of the pain medicine, so their VAS score, pain score is likely to be higher on average than somebody else who's, give it to me, I want the medications. So there's variation there. But I do think that's a large part the patient expectation coming in, as well as going back to my lecture on the advocacy regulatory, right? Look what happened with narcotics. And it was a little after, I don't remember the exact year, 2002, somewhere around there, American Pain Society came out and said, oh, pain is undertreated in the hospitals, and JACO picked it up, and right, pain became the 5th vital sign, and oh, everyone needs to treat it more. And I don't think it's as much a problem within our specialty and community as the people outside of our community. So you get more prescriptions for narcotics, right? If you look at a curve, I don't have the graph with me, but you know, you look at number of prescription opioids prescribed, it totally jumps up. And then you get narcotic, right? People who become addicted because it's out there and laying around in the cabinet, and other people take it. And now we know about opioid-induced hyperalgesia, so it might be bad. And now the pendulum's going back the other way, right? They're arguing, oh, doctors are overprescribing, it's bad, you're causing this epidemic. I mean, are we being recorded? Never mind, I can't tell that story.
No, that's a good example of how I think for big groups or even little groups, it pays to really be the owner and manager of the data that's being collected, so that when you have the discussion about HCAHPS between an unmedicated delivery and a patient who received lumbar analgesia, you can really, instead of being defensive about why the scores are what they are, or being defensive to the hospital or whoever's paying you, you can actually be proactive and say, okay, this group of patients doesn't apply because they had natural childbirth and we had nothing to do with them, but unless you manage and own the data. And so you need to have people in your group who are keen on doing that kind of work. It's not for everybody, but it's a lot better, easier to engage in a discussion if you actually know more about the data than the other side.
One final one-sentence answer from each of you. What are you doing? What's your number one priority in terms of improving your HCAHPS? And maybe I'll ask the rhetorical question that was in the book. Why is anesthesia always blamed? I assume that was rhetorical. Good question. Any recommendations, individual strategies that you're implementing to improve your HCAHPS?
I mean, one thing I look forward to doing when I have some more time, which means after June 4th when I'm no longer president, I want to spend some more time. I get a lot of rotators, and it's hard to teach them, I find hard to teach them that patient experience component, because they're always coming and going. And I'm going to personally try to create some kind of educational program or 1-hour lecture that they have to do before they rotate through, just some of the basics on Over the years I picked up, you walk into the room, sometimes the vibe is off, or, but sort of try to standardize the introduction, some of the things, so it's a more positive. Like when you go to I remember one time I went, to a nice hotel, and they were like, "Oh yes, my pleasure," and this. There's some of that can make an effect than just like, "Oh, I'm here to do the epidural."
I can
doesn't come
certainly
off
acknowledge,
particularly
the customer service
Yeah.
experience is harder
Right.
with a transient and ever-moving population in a
Right,
teaching
I
institution.
mean, with the Cedar's residents and my fellows, I've emphasized it, but it's hard with the rotators, so I think
Alex,
that's.
you got one? Quick one-liner before we go to lunch?
Yeah, this is a little bit different from what Mark is saying, but I know that at my hospital, we were able to get additional resources from the hospital to hire more pain nurse practitioners to be part of the acute pain service, to better manage the complex pain patients in the hospital, to try to improve the HCAHPS pain scores. And I don't know that those resources would have come as easily if the hospital hadn't prioritized improving the HCAHPS scores, and specifically the pain management question.
Yeah, I certainly, within a hospital administrative role as well, where money is always tight, but people are willing to dedicate resources to address some of their HCAP deficiencies. Use it to your advantage in your institution. Let's break for lunch. Thank you, panelists.
Great to see you.